Welcome to the CINP Leader Panel. My name is Siegfried Kasper. I'm the president of CINP, and I would like to introduce today a very timely topic on treatment-resistant depression, which I will discuss with my two colleagues, Professor Gobbi from McGill University and Professor Krystal from Yale University. Treatment-resistant depression is nowadays a big challenge for doctors out in the field, and specifically also for doctors working in hospitals, because more and more patients can be treated effectively out there in the field, but unfortunately in tertiary referral center, those patients are coming in who do not respond to different treatment modalities. Nowadays we know also that treatment-resistant depression can be treated effectively, and we know in the previous history those are the patients with a high comorbidity with anxiety disorders. They are those patients with suicidal ideation, and also those patients who have a number of phases already in their previous history. There's a large European data program which we call the Group for Study of Resistant Depression, which is done in Belgium, France, Italy, Greece, Athens, and also in Israel and in Vienna, Austria, and we collect a large number of patients, over 2,700 patients. Unfortunately, we could not find a biological marker as yet, but the clinical phenotype is very characteristic, how I just explained. So I would like to ask my dear colleagues what they think about treatment-resistant depression, and if I may start with Professor Gobbi. How is the situation from your point of view?
Yeah, treatment-resistant depression is today becoming a very important issue because more and more patients don't respond to SSRI or to SNRI, etc. So they come to see the psychiatrist sent by the family doctor to find other kind of strategies. So what is the best approach for these patients? First of all, to understand a little bit more about their history. Another very important point in my experience is also to make a precise diagnosis to differentiate if it's a real major depression or if it's a bipolar depression. Very often come to see a psychiatrist patients that have a bad diagnosis, actually are bipolar depression. And it is very important to distinguish the two kinds of depression because the treatments are completely different. While for unipolar depression, we have to go with different classes of antidepressant or typical antipsychotic. With bipolar depression, we have to start immediately mood stabilizer. Mood stabilizer is the key to treat these patients. In particular, we see a lot of patients arrive to our attention with a suicidation. In this kind of patients, if we make a diagnosis of bipolar disorder, it's very important to start immediately lithium, for example, because now there are so many studies that say that lithium is the best drug to prevent suicide and suicidal ideation. So, in my opinion, the first problem of treatment-resistant depression is the diagnosis.
Very good. Professor Krystal, what is your point of view on this topic?
I think this is, first off, an extremely important topic. I think one of the problems that can happen in the treatment of patients with chronic mental illness is that both the treater and the patient become discouraged, and they stop trying new interventions. They collaborate in giving up on the treatment, and dealing with that problem is a huge obstacle to successful treatment. And it's particularly the case when there are so many new options for treatment. Oftentimes these options aren't really considered very carefully. So for example, the use of electroconvulsive therapy or transcranial magnetic stimulation, or some of the newer medications like ketamine or esketamine. These are options that are not used as frequently as you might think they would be, since they're often helpful for precisely these kinds of treatment-resistant symptoms. So I think one of the most important steps is really that moment where the doctor and the patient realize together that the current treatments are simply not working.
Mm-hmm. No, thank you. I think this is a very important point which you mentioned, that the patient, but also the doctor gives up, right? Mm-hmm. And so sometimes we have also a feeling this is infectious, right? Because the patient tells all the different life circumstances, what he is in there, mm-hmm. and the psychiatrist probably says, well, it might be linked to your personality. And mm-hmm. then we have a personality disorder, and then some people try to have lengthy psychotherapies with mm-hmm. them. Could you say what might be the role of psychotherapy in this patient?
Yeah, this is a good point. The first approach I have with the patients with the treatment-resistant depression is to give hope. Say, look, we are not anymore in 1950. Now we have a lot of different medication, a lot of different psychotherapy approach, a lot of second step as, for example, ketamine or TMS. So we have so many things today that a patient with the depression, with treatment-resistant depression, can really have a very good, a very positive outcome. This is the first things. How we work with this kind of patients in pharmacology and psychotherapy is the following. The first things, we try to give a good pharmacotherapy to avoid the crisis. So if the patient has a suicidal idea, we try to address this with the medication. If the patient is very anhedonic, has fatigue, we try first to keep the patients in a manner that is able to work, to function. And this takes normally 2 months. After this, we address the patient to psychotherapy with a specialized team of psychologists that try to work on a particular feature of depression. And when you combine together this kind of approach, really works. Really works. After 6 months, 1 year, the patients started to go better.
Let me address to you also one important point. When we talk about treatment-resistant depression, we have new modalities which work. So isn't the term treatment-resistant depression completely wrong? Because the patient comes in and then doctor says, oh, you have treatment-resistant depression, and the patient says, oh my God. So when I look into the literature, then we find difficult to treat patients, multiple therapy-resistant depression. The lay press even writes about stubborn depression. Yeah. So the question is, aren't we using strange words for this kind of disease, which we have good treatments available? And the next question would be, do we have this kind of wording for internal medicine? I'm not aware that it's difficult to treat hypertension, difficult to treat diabetes. So in these areas like oncology, they talk about stages. So shouldn't we talk more about stages and get rid of this terrible term?
I think that's an interesting point. I've often talked about with patients treatment-resistant symptoms as opposed to treatment-resistant patients, because there's a tendency, I think, sometimes in our field to blame patients when they don't get better. Yeah. And it's really not their fault if they're actively engaged in treatment, it's just that they haven't responded. And I also think that this label treatment-resistant refers to the fact that that almost all patients get the same first-line medication, and that acts as a filter. But if we had a different kind of culture of psychiatry and we used other medications as our first-line medication, maybe we would have a different definition of what treatment-resistant depressed patients like. But sometimes I think also recognizing that you're in this state of treatment-resistant is a call to reevaluate the patient, and that's an opportunity too. You might discover occult hypothyroidism or some inflammatory state, or even undiagnosed medical conditions that are increasing inflammation in the body that are contributing to depression, or in the worst cases, brain tumors or strokes or other things. So I think there is an opportunity of making the most of that moment. It can be a very positive moment for people. But I agree that the label is a challenge.
Because it gets even worse when the patient gets treatment-resistant depression. Then the doctor says, I give you an atypical antipsychotic. So the patient says, oh, now I'm psychotic and atypical.
Yeah.
So luckily we have Professor Zohar here around us, and he would say, well, D2, 5-HT2 antagonist. So like we need to have more sort of clear message. So what do you think about that?
Yes, these are good points. So normally I don't use with patients the term atypical antipsychotics. I use, look, now I will give you some quetiapine or some olanzapine, but look, at very high doses used for psychosis. But a smaller doses we can use for depression, for sleep. I try to reinterpret, to rename, yes, the use of medication.
So
this,
in
I
Europe,
think,
we sometimes quote Paracelsus. Paracelsus is from Austria, right? So
yeah.
and he also, the dosage is important, right?
Yes.
So at least the Austrian patients, they respond to Paracelsus, right?
Yeah.
But I think the dosage is very important, right?
Yeah.
Well, this is one of the things, when we treated patients with tricyclic antidepressants, which is not very common anymore, we could be magicians. We could be incredibly effective. We would get patients in who would be on 25 milligrams or 50 milligrams of imipramine, and then they would not respond, and they wouldn't understand why they weren't responding, and we would increase their dose to 300 milligrams, and magically, when we got them to a dose that was actually antidepressant, they would get better, and we would be seen as masters. We've, in a way, forgotten that also the SSRIs and SNRIs have dose response relationships, and that some of these medications need to be pushed to the higher end of their dose to be effective with people. And I think that optimizing medications is really an important part of evaluating whether or not a person's really responding to them.
I think it's very important what we discuss here, that the term is not the bad, and probably we should talk about stages and neutralize everything, because otherwise also our colleagues from internal medicine don't really understand us, what we are talking about, and that we have a clear medical also nomenclature. And I once more would like to stress the international nomenclature project spearheaded by presidents of the different societies worldwide. They clearly indicated the nomenclature should be the leading word for our medication.
Absolutely. Also, because the patients today are very well educated, they Google a lot of things. So sometimes also explaining to the patients, look, now I give you SSRI that act on serotonin. Then I will add some quetiapine that act in a receptor called 5-HT1A or 5-HT2A. So you explain the mechanism, your rationale to the patients, and the patient can also follow you. This is very, very important.
No, thank you for joining me in for this important topic, and I do hope that we could bring out the message that there is a new treatment for this disease, for this group of depressed patients who do not respond to the first treatment. And this morning we had a wonderful talk from Dr. Krystal where he showed his own research, which he found out that there's a group of patients who responded worse than even placebo. So they have a different biology. That's a very clear message. Thank you, Raj, for joining in.